And good evening, everybody. Dr. Bill Tulo, Medical Director at Oculus, and welcome to the Oculus Clinical Webinar Series. Tonight, I'm really excited to have two special guests tonight, Dr. Stephanie Ramdass and Dr. Matthew Martin. The title of tonight's lecture is Axial Length in Research and Clinical Applications, Why Axial Length Matters. Before I introduce our speakers, a little bit of housekeeping. If you have questions during the presentation, please place them in the chat and we'll do our best at the end of the presentation to answer all your questions. Tonight, Dr. Stephanie Ramdass has graduated from the Inter-American University of Puerto Rico School of Optometry, completed a cornea and contact lens residency at the Michigan College of Optometry. While at MCO, she also completed a clinical research fellowship at the Vision Research Institute and obtained her MBA degree with a focus on project management. She's also completed a Master of Science in Biomedical Sciences. Dr. Stephanie Ramdass is a member of the Ontario Optometric Association of Optometrists, Fellow of the American Academy of Optometry, Fellow of the Scleral Lens Education Society. She's also a committee member and contributing author for the International Myopia Institute. She's passionate about specialty contact lens education and has authored and presented globally on the subject matter. After graduating with honors in pre-optometry from Ferris State University, Dr. Matthew Martin attended Michigan College of Optometry, graduating with honors in 1999. Dr. Martin has served the mid-Michigan area for 20 years, providing comprehensive care, managing ocular disease, and fitting specialty contact lens designs. He specializes in pediatric eye care and myopia management. Dr. Martin has been a fellow of the International Academy of Orthokeratology and Myopia Control since 2003. He served on the leadership and planning board for this organization and currently serves in the fellowship testing committee. In 2017, he presented at the Vision by Design Bootcamp for newcomers and has since become a permanent member of the bootcamp team. Dr. Martin is also a founding member of Mission Myopia Control, an implementation company emphasizing education and implementation of myopia management in private practice. Without any further ado, Dr. Martin, why don't you start us off?
Yeah, first of all, I want to start out by saying how incredibly excited I am about the opportunity to speak about axial length, as it's become very near and dear to my heart over the last couple of years with regards to myopia management. So let's jump right in. First of all, you should be aware that the content of this webinar and the opinions expressed are solely the responsibility of Matthew J. Martin, OD, and Stephanie Ramdass, OD. And so that's very important for you to be aware of. Let's jump right in and start talking about the Myopia Master. The Myopia Master is an instrument that we've had in our office for quite a while now, and it was developed specifically for myopia management. It does a couple of things incredibly well. It does axial length measurements very well. It does keratometry, autorefraction, which is kind of interesting because traditionally we don't think of autorefraction being as important on an instrument that does axial length measurement. But I know we recently had our autorefractor down and we relied quite extensively on the autorefractor component from the Myopia Master, and it was really quite accurate. What I really love about this instrument, though, is the progress reports and, most importantly, the risk factor analysis report, which in my opinion is by far and away the best feature for this instrument. I have really come to like the combo aspect of this instrument, and it has really opened my eyes to axial length measurements, especially when they're done as accurately as the Myopia Master does them. So I'm going to turn the slides over now to Dr. Ramdass, who's going to talk a little bit about exactly what we're measuring.
Thank you, Dr. Martin. And I think the biggest thing when we are explaining, and I'm sure you can probably attest to this, is explaining to parents what axial length is and what why the meaning of the eyeball length is really important as our measure in trying to assess if we're making the proper judgments for what treatment of myopia we want. So my trusty eye model is my best use in our office. I always pick it up and I'm showing that we're measuring the length of the eyeball specifically. And then if we, depending on the instrument, we're looking at the combination of the anterior chamber depth, the contribution of the lens thickness, as well as the vitreous chamber depth. So that's an easy go-to for parents to understand. You know, I know we all have our different analogies when we're doing patient communication. Whether we say that that eyeball length is increasing like a compressed balloon, I know a lot of parents seem to understand that, and they, you know, either we're drawing it on a whiteboard, let's say for example, or we're using a model just like this to go ahead and get our measurements. We'll move on to the next slide there. You know, and I'm not sure how you presented in your office, Dr. Martin, but I know for me specifically, the benefit of using the Myopia Master as an educational tool is important in a dedicated myopia management consultation. So from practice management standpoint, there's only so much you can do in a baseline eye exam. It's great to plant the seed, but I do see value in maybe taking, that's the autorefractor feature is excellent. If we can get an autorefractor measurement and then a baseline axial length measurement in, let's say, our entire pediatric population when they come in for routine eye exams, that can be used as a potential stepping stone to bring a patient back for myopia management consultation. So why did I decide in clinical practice that it was really important to have a dedicated time? I got bit in the butt, so to speak, by a patient who I was trying to do my drawings for the mom, and there was a language barrier and she just wasn't understanding. And I think for her, it was just too much to grasp that there was something wrong with her child. And I had a 15 to 20 minute time slot. And instead of doing good, she literally left the office in tears. And since then, having a dedicated time where we can educate patients on either confirming what the refractive error is. We know from a lot of our studies that the outcome measures based on cycloplegic refraction are important for us to really decide what the true level of myopia is and making sure we're not over-minusing any of our kids. And then using all that gathered information and comparing them to age expected norms is excellent during a dedicated time period that's outside of that baseline eye exam. Parents can take home information from that visit. You can then answer questions that they have, and then you can go ahead and, you know, make a uniform decision as a family or as part of their family as to what's the next best steps. If we go on to the next slide. So how do you approach this, Dr. Martin? Do you guys have a separate consultation visit, or do you do it all in one shot?
Yeah, no, we absolutely have a separate visit. So the initial examination is just planting seeds for what we want to bring them back for the consultation. So it's along the lines of, geez, your child is a little bit nearsighted. I have some concerns. We're going to bring them back Wednesday evening at 6 p.m. It's our last appointment of the day. Let's take a look at what options we have, what things we might be able to do. And in the meantime, I have a sheet here, and the sheet lists the 3 most common myopia management options out there. I'll send this home with you. Take a look at it. When you come in, we're going to collect axial length measurements on the Myopia Master. We're going to discuss the ins and outs of this. We'll talk about what things you're most interested in pursuing. And then hopefully we can even jump into maybe putting an ortho-K retainer on a patient within the bounds of the exam room. So I absolutely believe that you're going to have a consultation visit that is a separate visit. And I make a strong argument for doing that as your last appointment of the evening. It's the best way to have the time to do it. If you feel rushed, you're not going to have as good of a conversion rate as if you take the time and have the time in your schedule to be successful.
100%. And you talked about flexibility of the schedule. I know certain offices may not be open on weekends, but allowing parents to get that chance to come in and bring their child 6 p.m. after school, you know, having that dedicated time where they can sit and getting maybe other family members on board, I think are important. It's good to understand the genetic background, obviously, for that patient and their family. And then overall, paint the picture. What risk are we determining? And you'll see through a series of examples that we're going to present that every case is individualized. Like no one case, I know we're trying to find like the perfect cookie cutter method in order to implement myopia management, but these tools are really helpful in order for us to determine the next steps. I know, you know, for decades, we were just managing myopia by looking at the dioptric value change over time. I remember I was attending the FDA meeting. This was back in like 2016, I think, where a group of ophthalmology and optometry, as well as FDA health officials, came together to discuss where the field of myopia management was going and how to implement treatment that would be approved. And at that time, it was questionable. They knew that axial length would not be something that everybody would have access to, but it wasn't necessarily considered standard for managing and as an outcome measure to see if treatment was effective. But since then, I feel that the field has definitely taken over, and it's almost going synonymous with measuring myopia. You're measuring the axial length to ensure that you're giving proper treatment protocol. So if we move on, the diagnostics that you can show during your consultation visit, which include all of the visuals, I think are the most effective. We'll talk a little bit as we go on to the eye axial length charts. These prediction graphs are great based on percentiles. We can kind of see where the 50th percentile of a population would be, and then where you potentially can see that child being outside the realm. You can see how easy it is to see where a child will fall outside a particular graph and be on a path that is not within their norms. You can get your axial length measurement. I'll talk a little bit later on about the repeatability and accuracy of this number. As well, the refractive error is great. If you've already confirmed refractive error, doesn't hurt to have it another time to ensure where you're going forward. I think another important part of that myopia management consultation, depending what you're going to, what treatment protocol you're going to follow, is the pupil size. And that is something that you can get an image of in addition to measure and discuss with parents as well from the screen, how your particular treatment might be affected by the size of a child's pupil. So all great visuals, and you'll see how we then implement these through the cases we're going to discuss going forward.
Next slide.
Next slide, please.
Sounds good.
So how exactly are we reading these growth charts? Are we comparing apples to apples? Now, the original database that we had in the Myopia Master was comparing age and gender norms to a Asian population, but it has been expanded now where we can compare to different ethnicities. So it's also important, think about like your child going to like a pediatrician and you're looking at those percentile growth curves. It's important to understand you are not necessarily, it's not an absolute value, and we're not, you know, set in stone. It is something that we're using as a benchmark in order to measure for our child, and like all the children that are going to essentially be within that database. But again, most of these charts are based on populations that are between 8 to 13, 7 to 12. It's a lot of the research comes from the normative database of those particular realms. So if you have a child who's 3 or 4, yes, you could obviously take it. They're in clinical practice, there's no reason why you wouldn't. As long as you can get that patient on the stool and their chin in the chin rest, you'll get a value. You'll get your measurement for axial length, but you have to just be able to read it with a grain of salt to know that that age norm is not typical of that growth chart. And so that's just something to keep in mind as you educate your patients.
I think that also speaks to, if you can collect axial length measurement from the parents, sometimes that can also be incredibly valuable. I've often had people come in or children come in for a myopia management consultation. And while they're there, I'll spot the parents with a big prescription. And I'm like, hey, let's run you on the axial length measurement as well, because sometimes you can get a real inkling or a real idea of where we're going with that based on the genetics of the parents as well. Do you feel the same way, Dr. Ramdass?
You'll see in my last case, that's exactly what we did. I don't want to go
I'll pass it back to you again.
Thank you. I think a great takeaway too is the printouts that you can hand off to parents. So say, for example, you gather all the information and they're still on the fence. I like to send off kind of where the patient's risk profile is and what treatments that I've recommended. And then it's a great, like, I have parents that come in with little folders, and these folders contain all the packages of information that we've provided. So either I'm following up with printed material or following up with an email. It does take time, but at the end of the day, if you can answer a few emails and give a little bit more information, I completely agree that that turnover rate for a parent to decide to put their child in the myopia management treatment protocol with your particular office. I know for us here in Canada, we've got kind of like an entire toy chest here of options to work with. And so there are many offices that are doing myopia management here. So you want to, one, stand out as a clinician that has a wide range of options. But two, I mean, do you take the extra time to ensure that parents really understand what's going on? And do they go home with metrics to see, okay, little Johnny was here at baseline, how did we improve over time, and where did we go? And I think that's important for the kind of the journey of the patient in your office getting care. Back to you, Dr. Martin.
Thank you so much. This is actually your slide one more time. I think
Oh.
you're showing us the options you've got compared to what we've got.
Yeah, so do you feel limited in the options you have right now?
Yeah, we're limited. We don't have access to the spectacle lens component right now. That's the big take-home message here. That will be coming to the general population, I assume not too terribly far in the future.
So I'm going to ask again, do you feel limited? Do you feel that your practice is not
Yeah,
limited?
I have a certain amount of patients I think would benefit from spectacle options, but for
Yeah.
the most part, we do very well with the standard, atropine peripheral defocus contact lenses and ortho-K. I feel very comfortable routing, the vast majority of my patients through there, but I do on occasion have kids who maybe absolutely can't take a drop or absolutely don't want anything in their eye, and it would be nice to have more glasses treatment options for them.
So as a prescriber of these glasses for over 2+ years now, I will say there's about 50% of my population that will opt for a spectacle option because, ease of use, that's what they know. They will look at the options and decide what's best for their family. And yeah, there are 3 big options that are available right now that we are providing. There are new ones on the horizon when it comes to spectacle lenses. But overall, it's providing a big picture as to what treatment option would be best. And this is where I really stress that it is individualized care. Whether we combine certain amounts, having that axial link to support all of this information is at the heart of what path you're going to take. So yes, the options are there, but realistically, it's the axial length that's going to drive which single or combination of options I decide to put in my patients.
And I agree 100%. Hold up, wait a minute. What about diopter power? I think this is really an interesting conversation, and you hinted at it a little bit earlier, but let's dig in a little bit on this subject. Do large prescriptions always indicate pathology? And then more importantly, perhaps, how does axial length or change in axial length and change in prescriptive power relate? And I think this is a really interesting conversation. So according to the Blink study, and that was Walling et al., 1 millimeter of axial length change was equal to about 1.44 diopters, and that was in the high ad group. 1 millimeter of delta was equal to 1.55 diopters in the medium ad group, and 1 millimeter of change in axial length, 1 millimeter change in axial length was equal to 1.63 in the single vision soft contact lens group. So I'm going to be running some numbers by you folks for just a minute. So don't get too hung up on these numbers. Just know that what I'm going to be showing you here does have pertinence to what we're discussing. So if we look at the MySight 1-day study, they said that 1 millimeter axial length change was equal to about 2.4 diopters of refractive change, okay? So if you're in the audience right now, you should be thinking, well, those are some pretty crazy differentials there. You know, how much does a millimeter really equal? So then they came along and they did the LAMP study, which was a very good study. And the LAMP study had information to tell us as well, okay? What the LAMP study basically told us was that it demonstrated a clinical disconnect regarding the relationship between change in axial length and change in prescriptive power, and that the change in prescriptive power did not correlate as well as expected. How does this affect us as practitioners? I think Dr. Ramdass indicated this earlier, but I think that the big take-home message here is that axial length data may, and I would even scratch that out and say is, a more meaningful measurement versus refractive change for patients undergoing low-dose atropine therapy and likely all forms of myopia management. Remember, dioptric change can change. We've even refracted family members who may, like your kids. Ever refract your kids? I've refracted my kids one day. I refract them the next day. The prescription's a little different. I could wait a week and check it again, and it might be a little different yet. And that's just in someone with a stable prescription. We know that changes in axial length measurements are much, much more consistent and a much better tool for measuring exactly what we're trying to achieve. I also think it's interesting to note that the difference in axial length data and how it correlates to the change in dioptric prescription, I've often wondered if that accounts for the rebound effect that you see when we take certain patients off of low dose atropine. So when it comes to my clinic, and Dr. Ramdass, I want you to chip in here, do you even care anymore really about what the prescriptive power is for a patient?
I do. It does play a role. I don't think that you can solely rely. Axial length has become the more important criteria. I will agree with that. And I do feel like my train of thought has shifted since I would say I started doing ortho K. So let's say it's been 10 years now I've been doing ortho K, and that really is where I felt that ortho K was mainly needed. If you're going to monitor the treatment, it's best to monitor with axial length changes only. But then when I went into clinical practice, I come from a research background for about 5 years of my career, and now I'm like 5 years out in clinical. It doesn't work that way. The axial length is really my big driver. I mean, we have the conversation in the exam lane, but I move over to the testing room, and that's where we finalize what we're going to do for our next steps, because they don't always correlate, and we know that there's more to it than just that one-to-one relationship. The curvature of the cornea is going to matter. Well, that's not a measurement that I particularly take myself in order to make a treatment protocol. I know that there's different elements to the eye that's going to make an impact where those numbers don't always go one for one. So I care about the number because I want to know where I'm starting, and that's the number that the parents are asking for. But they're also asking for, like, I have some parents that hold their breath before we measure axial length because they really want to know where their child's at.
Yes, and I agree with that 100%. I've been doing ortho K for about 21 years now. And for so many years, we would do ortho K. We would tell parents that we were doing a great job keeping their child's vision from getting worse, but we really had no idea of what was happening because we weren't washing out those children every year. That was just too clumsy. But way back in the beginning, we would wash people out and then try to figure out what their prescription was and then put them back in and ortho K retainers, and it just became, you know, not a good system. For me, the axial length measurement is, you know, really taking on more and more of an important role as time goes by. I do pay attention to the diopter stuff. I was just kind of throwing out to see if I get your opinion on that. So
Yeah, no, I agree though. There was a shift in my protocol some years ago with that.
all right, so let's talk about change. Let's talk about axial length changes. Axial length changes occur faster in young children age 6 to 10, and that's been shown with a couple of studies, and that's compared to older children age 12 to 16, and that was Breslin et al. And we also know that growth speeds up about 3 years prior and 5 years after the onset of myopia. Now, what's interesting about that is if you get kids in your office and you are routinely measuring axial length measurements, often we will see those axial length measurements change even before the child's prescription is changing. Inevitably, that prescription does follow the change in axial length measurement. But I have had cases where the patients come in, I'm checking them, I'm like, man, your axial length measurement really grew over the last 6 months or the last year. You still got a relatively small prescription, and then we'll see that patient and their prescription will have changed pretty dramatically to catch up to that axial length measurement. Is that something that you see in your clinical practice as well?
Yeah, as I'm starting to measure more as part of a baseline pediatric exam, um, and it's up to you whether or not you're going to. We'll talk about fee structure later, but obviously, if you're charging for this test, that's a different story. But you can see that ramp up of axial length change even before. Like there is that dioptric reference we use, like for the Cleary data. That's a big one. We're looking for our age expected norms for our 6 to 11-year-olds, but if we can get a measurement of axial length as well in there, it helps to show that speed up. And we can really talk as to whether or not maybe we increase the frequency at which we bring back kids for follow-up visits instead of seeing them back in a year. That helps drive the parents back for those follow-ups for sure.
Agreed 100%. We'll talk about that in just a few moments here. The big take-home message from this slide is the greatest acceleration is about 1 year prior to the onset of myopia. So what's the frequency, Kenneth? I mean, that's a great question. How often should we be measuring axial length measurement? What's the frequency? What's an appropriate timeline for measuring axial length measurements? For us, we had been doing ultrasound axial length measurement for some years before we ended up getting the Myopia Master. We had a DGH ScanFlex, which was inexpensive, although it seemed expensive at the time. And the problem was that ultrasound axial length measurement was clumsy and time consuming, which is one of the reasons why we struggled doing it as often as I think it needed to be done. So we were doing it every year or every 6 months, but it would take sometimes 10 minutes, sometimes maybe as many as 15 minutes to get good ultrasound axial length measurements on children. They don't want to hold still, they want to move their eye. It was very difficult. And we found that it was discouraging. So even though we were doing it, we weren't really using the information as efficiently as possible. So in our office, we changed our protocol to every 3 to 4 months. So that's either 4 times a year or 3 times a year. So we obviously do it every year at the comprehensive exam. And if you're in our myopia management program, we're going to do it at the no charge follow-ups about every 3 to 4 months. So I think it's important, and this is going to lead to a slide discussing some fees as well. So I think that's going to be pretty important here in a moment. We'll talk about the fees, but before we do, this is your slide, Dr. Ramdass. What are your thoughts on this one?
So when we are looking at, we're getting a little bit into the research side here. I think for a lot of us, we have to, the gold standard for understanding if myopia is working. And again, this goes back to that FDA meeting that I was talking about. Randomized controlled trials. There are several studies out there right now that look at changes in myopic prescription over time. But the randomized controlled trial, all of them have axial length as their one of their outcome measures. And so out of the main ones over the last decade, the number of studies is about 37, and axial length has to be in there in order for it to be determined efficacy. I know that there have been studies that just report on the dioptric value, and that may have been approved over time in reputable journals for publications, but it is not considered standard of care anymore. And then the amount of patients that are in there are usually like that 8 to 12-year-old group, 8 to 11-year-old group, 7 to 11-year-old group. And so when it comes time for us to determine if we're going to act based on the research, there's not much out there for a 3-year-old and a 4-year-old, but are we still going to measure? Of course we are. And so at that point in time, it is important for us to be measuring the axial length in addition to that dioptric value for us to know what the next step for. So obviously there's evidence-based medicine, and we know what the evidence shows, and we know what's right and most accepted in research for us to decide that we're going to make next steps. But if a 5-year-old walks in and they measure an axial length that's outside of that norm, I'm still going to treat based on what I know of for that 5-year-old is supposed to have. And you obviously have to educate your parents that the research doesn't necessarily show that this age group can benefit. However, here are the treatment protocols that we know that can prove to be efficacious, and then we're going to monitor over time. So that's kind of where the talking point starts. You don't necessarily step away from a child even though they don't fall within that randomized controlled trial that's the gold standard.
And I think also once you start doing this, you start getting a feel for it. If you get a child in and you can look at their axial length measurement and go, ooh, that's long already, yeah. Even though they don't fall into that classic study group because maybe they're too young or for whatever reason, in your heart of hearts what's going on, and you can start to get kind of a feel for what's happening there. I think the big thing is taking the measurements often enough and being aware of how they work really starts to give you some clues into what's going on. So I agree 100%. This is you again.
Yep. And so for the axial length measurements that we take in the Myopia Master, whether it's Myopia Master or any other tool that you use in your office, there's multiple options that we have. Typically that we're all within the ophthalmology space, but now have become optometry friendly as we expand our ability to treat myopia specifically. However, it is important that, I can probably ask you all those clumsy measurements that you took, like how many repeated measurements did you do back in the day?
With regards to the ScanFlex?
Yeah.
Yeah, a lot. We would have to take 3 or 4 or 5 measurements and kind of, grind them together and make a concerted effort to come up with an accurate number.
And so it's great within a, 15 to 30 second scan. We can get 6 repeated measurements with the Myopia Master. There is still some error that can happen, and I'll show you some outliers in a case that I'm going to present earlier. So it's always important, you can't necessarily see these 6 repeated measurements unless you expand your testing screen. And so I do think that that's really important to make sure you have uniformity, or at least a plus or minus within the measurements that you're using, to make sure that they are repeatable and accurate. And we do know from research that you potentially, depending on how frequent you're measuring your axial length measurements, you can have diurnal variations in it. So it's something important to keep in mind if you're noticing big changes within your patient population. Move on to the next one.
All right, so here's a question for you. Who do we measure and how do we implement this into our office flow, right? So clinical and studies are very important. Research is incredibly important. But what if we go back to our office and we want to figure out how to make this part of our flow and make this work well in our office? So I think that brings up a pretty interesting question that each person listening to this webinar needs to think about it. One of the options, and one of the more obvious options, is just to measure everyone under the age of 18. It's easy enough to get in the habit of just making sure that everyone who comes in under the age of 18 gets an axial length measurement. Another option would be to only measure nearsighted children. Personally, I'm not as big of a fan of this, but this is certainly something that you could consider. I do find it rather interesting that we'll occasionally come across farsighted kids with an elongated axial length measurement, and that can be an insight into a future changing for them, or a transfer from being that +1 child to that -150 child a year and a half later. And then what if you want to just measure everyone? Certainly that's something that would be on the table for some offices. It's going to kind of depend on what you think you can get your technicians to do and the efficiency of your technicians when using the equipment. Specifically, the Myopia Master in our office is pretty great. And so we have gotten in the habit of pretty much measuring everyone under the age of 18, with an emphasis obviously on our myopia management children. What is the protocol in your office, Dr. Ramdass?
Okay, so for every pediatric visit, there is a myopia management. So that's the autorefractor we use. So they just get shuffled in, and they don't realize that they're seeing the balloon. That's what they see, and so they're taking. They see the balloon, they get the measurement for their prescription, but then they also get an axial length measurement there. It's not necessarily discussed. That is something that our doctors are privy to, but at least that information is taken there at that first visit.
I think collecting it is absolutely important. Even if you're not necessarily overemphasizing it, at least you have it on record for them.
Correct.
Okay, so let's talk a little bit more about measuring, shall we? In my office, our protocol is to measure everyone under the age of 18 with an emphasis on nearsighted kids and obviously kids of nearsighted parents. Kids of nearsighted parents get more of a talking to about what we're measuring and why we're measuring it. Sometimes we'll measure children and, you know, we just keep it like you did there. And sometimes we emphasize it to the parents depending on what's going to be in everyone's best interest. So what do we do with this information? That's a really good question. Do we keep it safe? Do we keep it secret? No, that doesn't make a lot of sense. Obviously, measuring is nice, but I think the most important thing here is how do we then communicate this information to the patient? And then secondarily, how do I pay for the chair time and the equipment necessary to take and collect this information? I know that doctors in the audience tonight are very interested in axial length measurement, and I'm glad you guys are all here. But if you're like I am, anytime that I am in a lecture, listening to someone talk about axial length measurement, listening to someone talk about an instrument like the Myopia Master or one of the instruments by Oculus that measures axial length measurement as well as doing Scheimpflug topography, I want to know how I can pay for it because ultimately that's what needs to happen. So let's first talk about communication. The hallmark of a good doctor is the ability to understand a complicated subject and make it sound simple. And that's one of the things that was beat into my head in graduate school in optometry. And it's one of the things I've really taken to heart. And I think Dr. Ramdass touched about this earlier. So I'll give my example first, and then I'd like to hear what she has to say. So when we're talking, for example, about myopic maculopathy, when I'm talking to a patient about wanting to avoid some of the pathology that we associate with longer axial length measurements, I will talk to the parent about things like cataracts, glaucoma, myopic maculopathy, retinal detachments. And then I like to put together simple analogies when parents ask me specifically about these things. So for me, I like the analogy of discussing the concept of the eyeball getting longer and the sclera stretching. And I tell them the posterior pole gets kind of like a piece of pizza dough. If you stretch it long enough, it becomes super thin. And while we all might like thin crust pizzas, we don't want our retina to be super thin because that's going to be a problem for us later in life. I think, Dr. Ramdass, you were saying something about it squeezing a balloon. What were your thoughts on that?
Compressed balloon has always been my go-to, but I love the pizza idea. I think it's a little bit more real world in that sense. How often do you go around squeezing a balloon? Because truthfully, you squeeze that balloon too much, it will pop. Whereas the pizza, you know, you'll see a few holes in there. I like that.
Yes, you stretch that, you know, because my wife is watching that British baking show right now, which I'm dieting, so it's just killing me. But, you know, they're making bread. It was bread week, and they're making bread, and they're stretching it out really thin, and it gets so thin, it starts to get some holes in it. And I was like, that's what your retina looks like. That makes really good sense to me. And it's a good way for me to talk about myopic maculopathy or retinal detachments. So I think taking a complicated thing and making it simple, and then using that to draw back to the axial length measurement and why it's important for that parent to be getting axial length measurements, I think is absolutely the key. Now the process here though is that you all have to think about how you want to explain it in the simplest terms to the patient. And then another question that many doctors ask me is, how do we then pay for the instrumentation to offer this service? Like, it's great that I'm going to be measuring axial length measurements, and Dr. Martin says he does it every 3 or 4 months, but dude, that sounds like chair time, and chair time is money. So there's really 2 models you can do here. There's actually probably more than this, but these are the 2 main models. The model that we use is we include the fee for axial length measurements in our global fee. So what we do is we look at our global fee, we maybe will raise our global fee to compensate for the bringing in the extra instrumentation, and that way we're not hitting the patient every time they come in for a fee associated with measuring axial length. Other doctors measure a la carte, meaning they do their myopia management, peripheral defocused contact lenses, atropine, my perennial favorite, or not, I'm sorry, ortho-K, which is my perennial favorite, atropine, and then they charge the parent or the patient every time they come in for an axial length measurement. So they might charge 40 bucks or 30 bucks or 50 bucks. I'm not too sure what that number is, but I think it's interesting that those 2 models are how most offices that I have spoken to are doing it. Dr. Ramdass, have you heard anybody else doing a different method than this for taking into account the costs associated with measuring axial length measurement?
The only other one is like a combination method. So if you're outside, your package includes X number of scans, and if the parent wants to do any additional months, because that's just how they want to monitor their child, then you pay extra outside of it. I think that's the only way to sometimes, because I follow the global fee, but I will say that there are some parents that come in and want to come in on, a 6-week regimen because they want to know where their child is, even though they understand.
6 weeks is obsessive.
I don't disagree with it, but you'll see, I'll show you an example. It makes for a great chart. Don't get me wrong, I get lots of data. But you have to be able to draw the line. So I think that's the only reason I would say a combination of the 2, just to be able to make sure that you're covering your costs for sure. But I'm on the global fee standpoint. It's just easier to present a package and they understand the value of that package from the start of a contract
Even
that they sign.
ahead of time.
Yeah.
I lost you for a second there. So, okay, so we're measuring, right? So now we've got the measurements, but what is progression? I think that's a really interesting conversation to have. So in my office, I'm using a rule of thumb now where if I'm saying 0.06 millimeters of change in a 90-day period, extrapolated for 6 months, that's 0.012, or extrapolated for a year, it's 0.24. That to me says that I have progression of significance and I need to be considering initiating myopia management. What is your rule of thumb, Dr. Ramdass, that you're using when a patient comes in who maybe looks like they need myopia management, but you're not entirely sure if you want to go forward?
So I usually will see those patients on a 3-month basis as opposed to 6. Sometimes it's the parents that's on the fence and they don't want to necessarily initiate a form of treatment, but most of the time it's me that's like, let's put the risk factors together and see. And in that 90-day period, which is following that same 3-month span, I don't always get the same number of change, but I look at it as a repeated measure. Even if I have no change, but I have other risk factors that play a role, I might initiate even before I see a change. So yeah, I wish I had a hard set number. I don't have
Yeah,
one.
so this is a rule of thumb for me. Obviously, when it comes to clinical discussion, and I think that you made an incredibly valid point earlier when you said everything has to be done on a case-by-case basis. And I think that's 100% true. But I always like to have some number to hang my hat on. So this is how we do it in my office. But I think, like you said, taking into consideration risk factors, genetics, all that kind of stuff is absolutely essential. So how can I then use this number that I'm measuring? So if a child is already doing ortho-K, peripheral defocus contact lenses, or atropine as a monotherapy, sometimes we'll consider adding a second method of myopia management. So let's take a look at an example of this. So I have a child comes in and they're successfully doing ortho-K. So their last axial length measurement was 24.5. At the 90-day follow-up, I'm already seeing an axial length increase to 24.72, okay? Now that change is obviously more than 0.06 in 90 days. Sometimes when I see these significant changes, I will consider strongly adding low-dose atropine as a combination therapy with my ortho-K or with my peripheral defocus contact lenses. So one of the absolutely brilliant things about using axial length measurement, especially with your ortho-K cases, is it allows me to get an appreciation for the change in axial length measurement regardless of what I'm getting for refraction. Because sometimes I can have those ortho-K patients who are just rocking 20/20, no problem, but I see their axial length measurement growing. I know that I'm going to have problems if I do something about it. And oftentimes I will consider strongly adding low dose atropine. I'm a fan of 0.025% or 0.05%, by the way. Where do you fall on that scale? Are you in the same boat, Dr. Ramdass?
Well, I never do monotherapy atropine.
Oh.
And so my my 0.025 and my 0.05 are my go-tos.
Yeah, okay, so you're in the same boat that I am. Okay. So here's a case, a 14-year-old male, new to our office 1 year ago, rapid increase in RX sent in by a referring doctor, okay? So we did a cyclopenolate refraction on this young man, and he was -875, -7520, and -9.25, -75/135. So already a very significant prescription. So are we thinking ortho-K for this patient? Are we thinking atropine for this patient? Are we thinking peripheral defocus contact lenses for this patient? Obviously, for this particular patient, we ended up going with peripheral defocus contact lenses, as while I have done prescriptions this high in ortho-K, they aren't always the most fun for me or the patient. So his original axial length measurements were 2773 and 2796. And when he came back 6 short months later, he had grown significantly. So because he grew significantly and his growth met my new criteria that we talked about earlier within the 6-month period, then after taking that information and synthesizing it, we decided to add low-dose atropine of 0.05%, which seems to have slowed this young man down, interestingly enough. I wish I had the data on there. I must have somehow forgot to include that slide, but I do have data showing that the addition of the 0.05% atropine to his peripheral defocus contact lenses seems to have slowed things down for him significantly. So here's another case. This one's HS, a 7-year-old Indian female, 9 years old. So adjunct therapy, we were doing overnight ortho-K lenses and 0.025% compounded atropine. Oh, this is not my case. Is this your case I'm reading?
You can definitely run the
No, I'll let you read this case. I'm so sorry. It reads just like one of my cases. Let me turn it back to you, doctor.
I was just going to add on there, yeah, about half the age of your current patient. But the patient was already referred, already being on ortho-K and combination with atropine, but the ortho-K results were inferior in the sense that there was still a residual prescription. And so we did move the patient into custom ortho-K lenses to get a little bit of a better treatment outcome. But the pre-treatment prescription you can see here, and then you can see the NISO that's highly there, both in the prescription, and you can see the differential in the axial length, okay? 7 years old. We then, oh, sorry, can we move on to the next slide? I'm changing. At this point, because the patient was already on atropine, she had a large pupil size and was complaining of headaches, blur at near. She wasn't using any type of near ad or a reading pair of glasses on top of that, because her Ortho-K prescription, there's a little bit of residual. So they actually had her in single vision spectacles on top of the already treatment protocol she was on. And so at that point in time, it was important for her to get with atropine in. They wanted to have photochromic lenses for protection of any type of photophobia the patient was having. So at this point in time, what I decided to do while watching the axial length was to decrease, despite the fact that we had that large myopic prescription in the patients, we decided to decrease the dosage back to 0.025. Move on to next slide. So here, this is the serial mom who wants to come in for her frequent visits. So you can see that there's definitely more points here than even 6-week span. But the patient started off, and just like to reiterate what we're looking at here, again, you see the growth curve of axial length to age. You can see that 50th percentile. Most likely kids that fall above that percentile are going to project into some sort of myopia. That's no level of myopia is particularly safe now, but just outside of where that age expected norm would be. You can see that baseline left eye has, and I measured her probably like 8 weeks ago now, about 2 months ago. And so the whole point, and the mom is so pleased that we're able to at least, so she's still on the Ortho-K now, and she's on the lower dose of atropine. But you can see that there was actually a little bit of a dip in the axial length for the right eye, and then now we're almost like slowly bouncing up. And so the mom's like, whoa, I think maybe we should go back and increase that atropine dosage, which is something that we are is on the table because we have maxed out on our Ortho-K. I'm not going to add a third therapy. But you always need to keep in mind what else we could potentially add. And having these serial data points are great. Now, again, like if we look at it, this is a 26 millimeter to 27 millimeter. So we're within a 1 millimeter range here. So we're talking about tenths to hundreds of a millimeter of change. But it's still within a reason of, can we bring that eye back within the growth curve? And if not, what additional treatments do we need to add to get it that way? So great visual, and this patient continues to be monitored over time. So if we expand out, you can see where that differential. So at this point in time, if we saw that little dip, and I'll get into another slide a little bit later about axial length shortening, you can see that these are all repeated measures. So 26.6. We dropped down to about 26 point, like almost 3 here, but you can see we're creeping back up. So definitely part of the discussion as to whether or not our treatment is stabilizing the eye. 100% we can see that there is treatment efficacy here. Move on to next slide.
All right, so this is my slide, and I think this is interesting. So when myopia management is achieved, patients experience choroidal thickening. And I think this is really great because it can be really helpful in determining success of our management. I've even thought about implementing OCTs of the macula for all of my myopia management patients. I just haven't pulled the trigger on doing that yet. Do you know anyone who's doing that in our field on a consistent basis?
I personally don't, but I'm sure there are, as we know that choroidal thickening potentially could be playing a role, and especially with some of the new treatment options that are on the horizon, I do believe that there probably are some practitioners out there that are doing it outside of, let's just say, for research purposes.
Yeah, I think it could be interesting, I think, especially if I could figure out a way to measure that in there, but that's kind of a discussion for another day. Back to you.
So going right back to where you just talked about measuring OCT, I have, and I'm sure you probably have the same thing. There are some patients that show this shortening of their axial length. Now, is it true shortening or is it choroidal thickening? Now, whether or not we have those OCT measurements, we can't, but that same case I was showing you, there is that dip. And we do know at those youngest patients, those fast progressors, it's not uncommon. Studies have shown that you may see a slow dip off in the axial length to begin with, but that axial length tends to normalize as they get a little bit older, in the sense that it will creep back up. Not necessarily that they're potentially, the treatment is not efficacious or it's not working, but as they grow, you might see that change and where it bounces back up. And this dip here and this increase really did correspond with the growth spurt in my particular patient. So very interesting to see the numbers when you expand them out. Move on to the next slide. This is what I wanted to talk about with respect to the patients or the clinicians that potentially are measuring. It's on the horizon, the role of repeated low-level red light, and whether or not that is impacting. Some of the early results are showing very meaningful changes in axial length, more so than any of the treatment protocols that we start off with, which are about like the 50% treatment. And so this is exactly going in line. If that becomes more of, I don't even have that on my chart when I talk about options, but if that type of therapy becomes something more mainstream, then yes, I do see, just like how axial length had its time and place in our paradigm shift, I do think OCT might play that role as well. So I wanted to go over a quick case here, and this kind of dives into the same thing you were talking about earlier. So I had a patient who I saw recently, seen by a previous practitioner, no known axial length, it was just refractive error measured. At that point, it was known that she had a genetic history where dad had high myopia and mom had low myopia. So I saw her at 7 years old at an outside clinic, not in my practice. And at that point in time, this is a cycloplegic refraction. There's a little bit of myopia coming in with the right eye, but at that point, I don't know what her axial length is. So I brought her into my office and we did a repeated cycloplegic refraction. And then now we have that axial length in the picture. So she's still 7 years old. We move on to the next slide. So here is an example of a display. So you can see that prescription coming through. And then we get a lot of information on our display screen. So what's great is that you kind of, and I don't know which screen you prefer to use, Dr. Martin, but you have the printout on the Myopia Master screen, but you also have a built-in software that gives you a little bit more of an expansion on how you want to display the information to patients. And so we can see the axial length. And at this point in time, so what do we know about typical normal emmetropic growth in eyes? In infancy, around 16.3 is your, on average, research shows is where we start off with axial length, which grows to about 23.8 in adult range. And so we can see that this child is, yes, for 7 years old, she still has a little bit of hyperopia, let's say, on her belt, but if we do spherical equivalent, we're moving into that realm. Plus, we've got that axial length that's approaching outside of that range. So again, if you're on the fence, we know that the dad has high myopia, but if we move on to the next slide and we get more information, I decided to do exactly what you just did. I measured, or what you talked about before, Dr. Martin, I put dad behind the Myopia Master, and lo and behold, his axial length was 26 over 26. I myself am a minus 7.5 myope, so I have a very similar axial length measurement here, which comes with its whole slew of repercussions that we know of. And so at this point in time, we are choosing to proceed with treatment. Mom is very adamant on not using any drops at this time. With the myopia management spectacles, that's what she wants to do. Not all options here provide plano prescriptions. It might be plano with a little bit of sil. So that is also something you have to look at. Can we get a plano prescription with the treatment in the surrounding rings or contrast decreasing dots, depending on the type of lenses that we're going to use. Or the type of peripheral blur therapy that we're using. So unless you have all of these factors put together, and her environment is very limited, she doesn't have much screen time, but she's got that strong genetic history there. And so this is making or breaking us deciding to proceed with treatment. Would you treat this child, Dr. Martin?
You know, that's one of the ones that I probably would follow for a little bit longer. I'm not necessarily opposed to treating this child. I think I would be more apt to treat them if I had access to optical options, especially if mom is going to fight me on atropine. So, you know, this is one of those ones I probably would follow. I mean, it sounds like you're going forward with the optical option on this child. Is that correct?
The optical option is where we're going here.
Yeah,
But
I don't think there's any harm in that whatsoever. I'm not sure if I would want to toss this child into peripheral defocus contact lenses necessarily at this time, but I definitely would be leaning in that direction if I had access to that here.
If we move on to the next slide, we'll see the, I just wanted to show where her growth curve falls. Again, so the 50th percentile is kind of somewhere in the middle of this chart. You can see that she is outside of the norm for her age. So we know that she is going to be most likely progressing in that path with reasonable evaluation here. We can say on the screen, you can visually manipulate these adjustments here, and you can show where they fall. So with respect to myopia, just based on axial length, we're not the highest risk, but we're definitely at a certain amount of risk. We move on to the next slide. I show you the other metrics. In her particular case, she's got 2 myopic parents, one being high myopic in nature, which is pretty good. Her mom really makes sure she gets her outdoor time. And then I can just go ahead and drag how much near additional work she's doing outside of her schoolwork. So again, I don't necessarily, come up with like a overall number that I'm going to say, okay, your scale is, 6 out of 10, so let's go ahead and treat. It's just part of the comprehensive package we're going to provide with the patient. And so this is all part of us deciding to move forward with treatment. Move on to the next slide. Mom asked about lighting conditions. How many, the patient is sitting in bed. Should she be sitting there in the dark reading her books? No, obviously not. So she's not going to be measuring lumens in or lux in the child's room. But all of these things, like parents are asking of these very specific ones, and the lighting conditions do play a role, especially if we see that axial length continue to change for sure. Move on to the next slide. Now, what happens when it's still changing? What happens when you have adjunctive therapy and you can still see that axial length change? If we just move on to the next slide, I believe I have an image there of axial length. So here's that example of a child. There's a break here based on the data, but you can see young high myopic patient. She's about at minus 3.5 already at 6, but her prescription did continue to change. She's about at a minus 5 right now. You can see the axial length continue to increase despite the fact that we had her in myopia control spectacles. Ortho-K was not conducive to their family setup. There was about five kids. There's about 5 kids in the family, and the mom couldn't control, nor did the patient want anything in her eye. So while Ortho-K was my first line of treatment, I did, from a standpoint of efficacy, I do say to parents that we have about a 50% chance of slowing down progression with both Ortho-K or the spectacle option that we have available to us right now. And so do pay attention to the fact that there looks like there is this line here. These measurements, there's 1, 2, 3, 4 measurements that were taken on the same day. Now, this is why it's really important to train your technicians to know that there are outliers. And if you don't realize that this was an incorrect error, so you can see that this measures outside of the norm here, or outside of this pathway that we have going. These are data points that I would delete.
Did I lose anybody?
There for the purposes of this example here. But again, what do? She's already on 0.05% atropine. She's already on myopia slowing glasses. At this point in time, we have to consider, are there any, she has asthma, but she's been genetically checked for any type of connective tissue disorder. And so we're continuing to watch her. Now, it begs the question, if we had done nothing, and she's at -5, approaching -6 now, would she have been -8, -9 now? I mean, I don't know. I would never take her out of the treatment, but how much do I increase that atropine is kind of where my next steps are right now. So these complex cases wouldn't be having these discussions unless you had the tools in order to manage them and to educate on them. Move on to the next slide.
All right, so this is my slide. Let's talk a little bit real quick, because we've kind of run a little long here, on protocol changes. First of all, if you don't measure axial length measurement, you need to start. Secondly, you really need to be screening all kids 5 to 18 years old. And then optical biometry is superior, that's Lake Superior, by the way, for ease and accuracy compared to ultrasound axial length measurement. And then do you want to be exploring every 6-month protocol or every 90-day protocol? And if you do decide to do every 90-day protocol, you may need to take into consideration your annual fees, your program, and how you want to handle that so that you're making sure that you're being compensated properly for your chair time. I think that is our last slide, and I want to thank everyone for listening to us. Dr. Ramdass, did you have anything to wrap up?
Thank you, guys. Thank you, Oculus, for having us speak on this important topic. It's been great. It's been a real practice changer for me, adding axial length and measurements, because, again, it opens up a whole component of discussion with parents, for sure.
I think it's an absolute game changer when I can tell a parent, look, your child's axial length measurement is slowed dramatically, or maybe it's even stopping. And even though we've been doing Ortho-K for a few years and we don't think their prescription is changing, hey, their axial length is changing very little, and that's the take-home message.
Well, guys, this was the most comprehensive axial length conversation I've ever been part of, so this was fantastic. Thank you both so much. I know we have gone over, but I have a couple of quick questions I want to share. You answered the majority of the questions that were put in the chat and the ones that were submitted ahead of time, but a couple of things I think are worth reiterating. One, and I'll throw this out to either one of you, and the question goes, what about myopia caused by corneal steepness rather than axial length? Is there a theory of treatment still the same for refractive myopia caused by cornea steepening rather than axial length? And so do either one of you want to comment on a cornea steepening?
I'll jump in on that one. Corneal steepening makes me concerned a little bit about keratoconus. When you say corneal steepening, are you referring to dramatic steepening up to 48, 49, 50, 51? In that case, maybe we should be discussing keratoconus more than we're necessarily discussing axial length measurement. It's typical when I see corneal steepening to often see, if it's a mild amount, often see axial length measurements to go with that. Dr. Ramdass, do you have an opinion on that?
You hit it right home. When you say steepening, I mean, my forte is cornea and contact lens, and so yes, that's where I go. But if there is, if we're monitoring over time and you see change, and when you say steepening, it sounds like it's a series of measurements that you're taking. I would still treat if I notice changes in a dioptric value or axial length measurement value, but if the axial length is staying the same, then that's a different story. But most likely I'm treating to slow it down so that the axial length won't increase anymore. Again, it goes part of that individualized treatment. So if it's not steepening to the point where it's irregular, then I would treat based on what my typical protocols are.
Excellent answer. I think corneal steepening after the age of 5 is something that is atypical and should be investigated thoroughly for any early keratoconic changes. What about going back to something you mentioned before, the rebound effect with atropine? Do you guys counsel your patients or your parents about the discontinuation of atropine at some point, and do you taper it, or talk a little bit about the rebound effect and what significance, if any, of it plays in how you counsel your parents and patients.
I'll go first again, but I'm kind of greedy. Next time I'll let Dr. Ramdass go first. So for me, I was a little bit slow on the atropine usage in my office. We've been doing that for, I don't know, 5 or 6 years now. And a lot of my atropine patients are still on atropine. And a lot of the ones that I've taken off, I've done it both cold turkey and tapered. And I have not seen as much of a rebound effect as a lot of my other colleagues seem to talk about. So it hasn't been too huge of a factor for me. Dr. Ramdass, what has been your experience?
When you talk about those patients, are those monotherapy or are those adjunct therapy patients or a mix?
Referencing me?
Yeah.
Yeah, so it's a mix.
Yeah.
Some patients I just have on straight atropine and some patients I have on combo therapy. I tend to do more combo therapy. Being an ortho K guy for 20 years, I tend to reach for ortho K or peripheral defocus contact lenses as my first action. So a lot of times it's putting them on atropine along with the other things I'm doing. Although I do have children who are on just straight atropine therapy, and I have not seen, again, as much of a rebound effect as a lot of my colleagues seem to talk about. But it might be because my N number isn't that large. I haven't done 1,000 or 2,000 atropine patients.
Well, that's what I was going to say. I alluded to the fact earlier that I don't have many patients that are on it solely, and the ones that are potential, like for example, I gave a case example where I took a patient from a change in concentration, and I didn't notice that rebound effect. But if a patient's been on it for let's say 10 years straight, research has shown that it does occur, but there could be that disconnect where there's the clinical aspect of it and there's the research aspect of it. So I don't think tapering hurts by any means, but I've heard from multiple colleagues, yourself included, you just said some people have been taken off cold turkey and they don't notice a change. So axial length would be your greatest tool there to continue to monitor to make sure that there is no change.
So I have one final question for you, and this applies to both of you since you both practice significantly north of the equator. In the northern climates, how do you handle the time outdoors aspect? How do you counsel your parents and your patients about spending time outdoors, particularly in the winter seasons?
That's why we've got great snowsuits. It's lovely being outside. It doesn't necessarily mean that you can't go outside and obviously you can't ride a bike, but outdoor time in the wintertime is really important for us and here with parents as well. So it definitely is. You need more layers on, but it is still important. I do try to emphasize it. I just took my daughter last week. Actually, we're trying to get her into a daycare setting, and they've got their dedicated right through. These kids are 11 months old. They have their dedicated outdoor time as well. So it's definitely possible.
I suggest skis or snowshoes, or I buy them an ice fishing rod and the equipment. I mean, you can get people outside. It just takes more effort. And then also, I also counsel parents that we absolutely want to get kids outside, but I understand that sometimes it's not going to be as easy to do on the weekdays, and we need to try to make up for it on the weekends if at all possible. Here in Michigan, kids are getting home at 3:30, 4 o'clock. They've only got half an hour to 45 minutes, maybe an hour's worth of daylight before it gets dark. So I tell parents, we obviously want to get as much outdoor time as we can, but if we can't get it during the week, let's do our best to make up for it on the weekend, or let's just kick our kids outside for that last hour of daylight. At least they're outside.
Fair point.
Well, guys, thank you so much for sharing your expertise. This was an incredibly informative presentation. And I want to thank both of you for putting the time and effort into this. This was fantastic. And thank you everybody for coming tonight to the webinar. This has been recorded and it will be available in about a week to re-listen to if you want to re-listen to. If you think of more questions, again, my email is wtulo@oculususa.com, and I'm happy to send the questions along to the presenters tonight. Thanks again, Dr. Ramdass, Dr. Martin. Have a great evening.
Hi, guys. Thank you.